secret message. Yeah, can you hit the third button down on that now? You get started.
Good morning. Practices. Yeah, hold on for 1 second. I gotta-
So also in regards to mute epicondyle, the insertion site for the flexor pronator mass, the proponents of that are the FCR, FCU, FDS, and palmaris longus, as well as the pronator teres. We also have the ulnar collateral ligament, which consists of the anterior, posterior, and transverse segments, as well as the ulnar nerve. This is displaying the anatomy and landmarks of the humerus, radius, and ulna, comprising of the elbow joint. Just highlighting the lateral portions. So we have the lateral condyle being highlighted here. medial epicondyle is being highlighted in this. So the flexor pronator mass also has a proximal insertion at the medial epicondyle. As a result, consideration of conservative versus surgical relies on anatomy, as unstable fractures can result in deforming forces. The most common neurological injury is to the ulnar nerve in 10 to 60% of fractures. The medial epicondyle contains the groove for the ulnar nerve posteriorly, the structure which is most at risk from both injury and surgery. The ulnar nerve derives from the medial cord of the brachial plexus from C8 to T1, and the C8 and T1 roots. It enters into the cubital tunnel as it passes under the medial epicondyle and rests against the posterior segment of the UCL. Compression of the nerve can occur as it passes posterior to the medial epicondyle and beneath the cubital tunnel retinaculum. It is also the attachment site for ulnar collateral ligament. The ulnar collateral ligament originates from the most inferior portion of the medial epicondyle. It is composed of anterior, posterior, and transverse segments. The anterior band allows the UCL to remain taut through full range of flexion and extension, while the posterior band provides stability and flexion. In terms of stability, the anterior is greater than the posterior, as studies have shown sectioning the posterior portion of the UCL doesn't substantially alter elbow stability, versus marked valgus instability with disruption of the anterior band of the UCL. The previously mentioned transverse band, aka Cooper ligament, is less well developed and does not contribute much to elbow stability. So a little bit about mechanisms of injury. So direct blows typically result in fragmentation of medial epicondyle, along with soft tissue swelling and echymosis. The avulsion mechanism is an indirect muscular pull by the flexor pronator mass. This specific mechanism is described as a valgus stress on the elbow joint while falling on an outstretched hand of the elbow in extension. And there's further stress placed on the medial epicondyle with forearm supination and wrist and hand extension. Isolated avulsions of the medial epicondyle have been documented in adolescents who arm wrestle as a result in sudden increase in tension of the flexor pronator mass, which places tension on the epicondyle itself. And also dislocations of the medial epicondyle can result in fragmentation and incarceration of the joint before or after reduction, which is a definite indication for surgical management. So here's our case. We have a healthy 11 plus 4-year-old girl who's a right-handed gymnast who has been doing gymnastics since the age of 2. She participates at a high level. 2 days ago, she landed sustaining a displaced left medial epicondyle fracture. She was seen in urgent care and forearm x-rays confirmed the fracture. She was discharged, splinted, and an ACE bandage. She has been quite uncomfortable for the last 2 days. For physical exam, her skin was clean, dry, and intact, devoid of rashes or lesions. The ACE bandage was removed from the left elbow, and they revealed moderate elbow swelling of the medial epicondyle, and there was medial epicondyle tenderness with slight crepitus. The elbow is clinically reduced. She has no olecranon tenderness, no lateral condyle tenderness, no radial neck tenderness. Her forearm is soft, and she denies pain on passive extension. Wrist exam is normal, and she has full finger and thumb mobility. She is neurovascular intact. So CT scans, the standard radiographic evaluation for elbow injuries involve AP, lateral, and internal oblique radiographs at the initial visit. You can also consider a 3D CT scan within the first week of initial treatment if a non-displaced or minimally displaced fracture of less than 5 millimeters of the medial femoral epicondyle was diagnosed. CT scans are more accurate and show that displaced fractures are more anteriorly placed than appreciated on x-rays, but are also associated with higher exposure to radiation. Testing for medial instability involves a gravity-assisted valgus stress test that can be performed preoperatively with the patient lying supine and the arm abducted in 90 degrees. The shoulder and arm are externally rotated 90 degrees with the elbow held at 15 degrees of flexion, which eliminates the stabilizing forces of the electron. And then we have ulnar. So radiographic orientation. In radiographs, we focus on the anterior humeral line, the radial head, capitellar line, and Bowman angle. So line A denotes the anterior humeral line, which are useful for gauging normal radiographic alignment. This line should bisect the middle third of the capitellum in a child older than 2.5 years old, but in younger children, it may intersect the anterior third of the capitellum. This is because the capitellum is not significantly ossified at the time, so the line falls a little bit anteriorly. And in children older than 5 years old, almost 100% of them have anterior humeral lines that bisect the middle third of the capitellum, as long as you have a good lateral X-ray. To obtain an optimal lateral view, the posterior supracondylar ridges of the humerus are superimposed, which has been described as the most accurate method of confirming a satisfactory lateral view. The radial tuberosity is oriented anteriorly, and the radial head and coronoid process are partially superimposed, and the olecranon process is viewed in profile. Line B on both the lateral AP images denotes the radial head capitellar line, which is also useful. Is also a useful gauge for normal radiographic alignment. Angle C denotes the Bowman's angle, which is a line drawn down the humeral shaft through the capitellar ossification center. The more horizontal the perpendicular line looks, the more varus the elbow is. And typically, everyone has a slightly valgus angle. And you can demonstrate that on yourself by extending your arms out and viewing a slightly valgus. Some more radiographic orientation. This highlights some ossification centers. Again, the mnemonic CRITSO can help you remember what that consists of. And something important to note is that the trochlear and olecranon centers are often multicentric and should not be mistaken for fracture fragments. But the internal epicondyle always ossifies before the trochlear. It's also a key thing to note. This is our patient's x-rays. A review of outside x-rays of the forearm show displaced left medial epicondyle fracture, over 5 millimeters displaced. The fracture does not appear to be incarcerated. Image 1 is an AP radiograph of the left arm with padded long arm base bandage. Image number 2, the top, indicates a lateral radiograph of the left elbow flexed at 90 degrees with arm and supination. And here you can, it's not the best image, but there's superimposition of the posterior supracondylar ridges of the humerus and partial superimposition of the radial head and coronoid process. Image 3, we have a lateral radiograph of the elbow flexed at 90 as well. Might be slightly better. In image 4, we have internal rotation oblique radiograph of the left arm extension. So the AP radiograph reveals a type 2 medial epicondyle fracture. Classification. Classification is based on the AP radiograph, which allows for significant variation in measurements due to factors such as radiographic positioning and alignment. Wilkins classified fractures as acute or chronic, with acute fractures subdivided into 4 categories. We have acute, which could be non-displaced, minimally displaced, significantly displaced, fragment, and trapped in the joint, fractured through the epicondylar apophysis, or chronic. Chronic injuries are related to tension stress injuries, as in Little League elbow syndrome and young baseball pitchers who throw in excess, as well as young pitchers just learning to throw curveballs. The Watson-Jones classification consists of type 1 through 4 fractures. Type 1 fractures, which are considered less than 5 millimeters displacement with no rotation, are typically managed conservatively. Type 2 fractures, which are greater than 5 millimeters displacement with rotation. Consideration is given to patient factors along with amount of displacement for the course of management. Type 3 fractures have incarcerated fragments without dislocation. And lastly, type 4 fractures are incarcerated with dislocation. Both type 3 and 4 are surgically. 60% of fractures are associated with elbow dislocation. 75% are in boys between the age of 6 to 12 years old. And 20% of elbow dislocation, the fragment is incarcerated within the joint. And medial epicondyle fractures compose or comprise of 12% of all elbow fractures in children and adolescents. A well-padded long arm posterior fiberglass splint is applied with the elbow flexed to 90 degrees, fully supinated. The patient tolerated this well and is much more comfortable on completion of the splint. She is a high-level athlete, a high-level active gymnast, and wants to return to gymnastics. And this table just displays relative indications for non-op versus operative management. So ultimately, consent is provided for an open reduction and internal fixation of the medial epicondyle after discussion with the patient and the family. There were no absolute indications for surgical management, and the absolute indications include the joint being, the fragment being incarcerated within the joint or open fractures. As previously stated, consideration of the amount of displacement, high-level athlete status as a gymnast, and age were all relative indications to operate on this patient with type 2 medial femoral epicondyle fracture. Much controversy regarding the medial epicondyle fractures centers on how much displacement is acceptable before surgery is necessary. Both the amount of displacement and how to measure the displacement are controversial. Additionally, due to conflicting reports of non-surgical outcomes, consensus in defining significant displacement that may warrant surgery is even more conflicted. Patient suffered a vertical shear type split off the medial aspect of the femoral shaft, which was a separate piece of bone not connected to the remainder of the medial epicondyle. A dental pick was used to reduce the fracture, and one K-wire was utilized to hold the fracture in place. Under fluoroscopic guidance, a 3.5 millimeter partially threaded cannulated screw with the washer was placed over the K-wire, providing good compression of the screw. As the medial epicondyle is a posterior structure, the screw is typically oblique, directed from medial to lateral, and from posterior to anterior up the medial column. Care should be taken to avoid implant placement and the electric faucet that can result in implant impingement and loss of extension. And these are post-op or fluoroscopic images and post-op. There is much controversy in using radiographs to accurately measure medial femoral epicondyle fragment displacement. As previously stated, the medial epicondyle is located posterior, medial, and fragment displaces medially and anteriorly. This study, conducted by Edmonds, aimed to evaluate our ability to discern and measure fracture displacement and to determine the most valid and reproducible imaging method for classifying these injuries. This study doesn't attempt to determine fracture amount of acceptable fracture displacement, but it instead compares the accuracy of radiographs in determining the amount of fracture displacement radiographically for fractures deemed to be minimally or non-displaced with that of 3D CAT scans. Resolution of the controversy regarding surgical indications can be mediated by agreeing on the most valid and reproducible method to determine the injury pattern, which involves assessment of fracture fragment, displacement, and associated injuries, consensus regarding the effective skeletal age of the injury pattern, and also consensus regarding acceptable amount of fragment displacement as it relates to functional outcome. And only after these 3 points are agreed upon can various proposed interventions be evaluated regarding the risks and benefit of the desired outcomes. So all but one of the initial lateral radiographs in which the fracture fragment was visible, anterior displacement, the fracture was immeasurable and therefore recorded as 0 millimeters. The mean was 0.9 millimeters. Medial displacement on the AP radiographs was a mean of 3.9 millimeters with a range of 0 to 8. And mean displacement on the internal oblique radiographs was 6.6 millimeters with a range of 0 to 10.5. In contrast, the anterior and medial displacement measured on CT scans were 8.8 with a range of 0 to 15 millimeters and 0.3 millimeters, respectively. The measurements were significantly different from the comparison of lateral radiographs and CT scans for anterior displacement. and in the comparison of the AP radiographs and CT scans for medial displacement. The comparison of internal oblique radiographs and CT scans with regard to anterior displacement demonstrated equivalent results in 3 of the 6 patients, but the mean results were significantly different. In the study that demonstrates that standard AP radiographs and lateral views are neither sufficient to measure anterior displacement of the fracture fragment nor accurate enough to measure medial displacement in this injury. Internal oblique radiographs appear to at least approximate the amount of true the amount of true anterior displacement. However, if warranted, a 3D CT scan can be used to accurately determine the amount of displacement in all domains. Table 1 highlights demographics of the patients in this study. There were 261 males, 132 females. And table 2 highlights the findings of each individual study. 92.5% of patients who received operative treatment have bony union at final follow-up, compared to 49.2% of patients treated non-operatively. So overall, the review found that non-operative management of epicondyle fractures has reported problems, including unrecognized incarcerated fragments, ulnar nerve dysfunction, tardy ulnar neuritis, malunion, loss of terminal extension, and discord between patient and family expectations for high functional activity and ultimate functional result. Literature suggests operative fixation has increased in most centers despite the lack of scientific evidence that patients do better with anatomic reduction. Anatomic stable fixation remains a possible, yet not proven advantage in athletics and sports with heavy demand on the dominant elbow. Anatomic reduction is ensured with open reduction and internal fixation, so there isn't much surprise that bony was significantly different between operative and non-operative treatment. Though the question still remains, what is the significance of superior bony reported by surgical intervention? So in summary, operative treatment offers a superior rate of bony union compared to non-operative care. There's no difference in pain at final follow-up between both the operative and non-operative groups. No statistically significant increase in incidence of ulnar nerve complications with operative management. And as the functional demands of young patients increase, the relative indications for surgical fixation must be carefully weighed. And this is an algorithm derived to management. Turner oblique radiographs may be a safer method for determining anterior displacement, but CT scans may be the only accurate method to assess true displacement. The most plausible indications for surgical fixation are fractures with more than 5 millimeters of displacement, a positive stress test under anesthesia, or a patient who requires a stable elbow for participation in their sport. The intensity and duration of modern day sporting activities that push the functional demand of athletic performance of the elbow and shoulder to its maximum necessitates stable mechanics for optimal performance, not considered in many of the earlier studies. The goals with operative fixation are to maximize the possibility of early return to full function and high-level activity and to minimize late deformity and the likelihood of stiffness, as with prolonged cast mobilization. References. Take questions.
David, I thought that was a great talk, and thank you for giving it to us. Picking up anterior translation is really interesting, and you have to weigh the costs and benefits of getting a CAT scan on these kids. And I think it's a very narrow range, ones that are, maybe a high-level athlete that you're not sure if they need an operation or not. My question for you is, let's say you leave a kid alone that's 12 years old and plays gymnastics and it was displaced 1.5 centimeters. What kind of problems do you think they'll have when they go back to their sport?
So considering the literature, the main problems that I came across were more or less loss of I don't want to say this definitively, but it's a slight loss of extension in these patients. But the studies have shown that in regards to extension, the loss may be around less than 5 degrees of loss. So considering the demands of a high-level gymnast, these athletes are constantly extending and flexing their elbow. A 5-degree loss, to me, I don't believe that would be too detrimental to this type of athlete.
And that's interesting. You know, I was also thinking they may have a perceived instability. So, you know, where if they have to plant on their hand for a gymnastics maneuver, their arm might not feel as stable, or because of the laxity on the medial side, they may have some sprains and strains around the level of the elbow as those other muscles and ligaments help out. So maybe the PEDS guy know more about that, but that would be my worry about just leaving some of these injuries alone.
So the
Yeah,
literature
it's
actually,
mostly instability. You're kind of right on it, or a feeling of they'll call it kind of quote unquote weakness, that their arm doesn't feel as strong and it gives out on them. Because sometimes it's hard to get instability from kids. They can lose extension, but they can lose extension with non-operative treatment too. And in gymnast, even 5 degrees is kind of a big deal, because if you have to get both hands down to plant, and one hand doesn't reach the ground at the same time, that's a big deal for them.
I would comment that the only problems with have been kids that the epicondyle was small. I had one kid who had some bad HO on the lateral side of the elbow, and Dr. Blicka and Dr. Monica and I took that HO out and finally solved some of his problems. And that was related to the injury, I think, not the surgery. But I think that in my experience, you know, I've read the literature. I know what the you know, kind of indications are, and looking at, you know, some of these axial imaging and you know, some specialized radiograph imaging. I always think it's hard to judge displacement, and I think I had that conversation with the family, and I think that the wrestlers and the gymnasts are the two people I generally recommend. And I haven't found somebody I've been unhappy with who was not one of those two athletes who I left alone non-operatively. Now, if they're really close to the joint, you know, and there's gross displacement, you know, I have tended to fix them. And I think Steve Adelson, you know, has a comment. Steve's away this week, so he's not chiming in, but he would say, you're basically making a choice. You're going to accept that you're going to have a fibrous union there because, you know, with that large gap, you're not going to have chondrocytes jumping to heal there. You're basically accepting a fibrous union. And if you have relative stability of the elbow, you may be okay. But in that higher level athlete who's already committed to those sports, maybe you won't be happy. And so generally, gymnasts, I think wrestlers usually have fracture dislocations that are incarcerated anyway, so I'm fixing them. That's how they usually present. But you know, other than that, I haven't been unhappy with non-operative, but I'm only one voice of many on this topic. Nice job, David.
thank you. Depends on who you are as a patient. Your factors are huge determinant. So again, in like a high level athlete, you likely would benefit from a more a bony unit versus a fibrous unit. But for, you know, the typical late child who plays the Nintendo Switch at home, a fibrous unit wouldn't be too bad. Right? Open fractures. So then we'll go with the fragment incarcerated within the joint. apophysis. I'm going to say no. The screw can likely stay in. And to answer the question, it won't affect the growth because an apophysis doesn't contribute to the longitudinal growth of a bone as opposed to an epiphysis. So the screw can likely stay in. I'm saying that because the studies that I've read, I haven't read any patients going back in for removal. So the screw can stay in long term, won't have any detrimental effects on the patient or bone.
Morning, my name is Yesha. I'm one of the fourth year med students, and I'm going to be presenting on osteonecrosis of femoral head, also more commonly known as AVN. These are the objectives for today's presentation. So we'll start off with the case. This patient is a 50-year-old male with increasing right hip and groin pain over the past year. He has tried Aleve and Tylenol with minimal pain relief for more than 3 months. He has pain with weight-bearing activities, which affects his ability to perform daily activities. Past medical history is significant for osteoarthritis. Social history is significant for alcohol use. He has no tobacco, corticosteroid, or recreational drug use. Physical exam is notable for limited, painful internal rotation. X-ray images were obtained for this patient. On the left, we have AP films, and on the right, we have a frog-leg lateral of his right hip. We can see that there is some changes in the superior aspect of the femoral head. MRI images were also obtained. These are his T1 images. There's also a low intensity signal that is present in the superior aspect of the right femoral head shown on these images as well. These are the T2 images. There's a high intensity signal also present in that superior aspect of the femoral head. So this patient was diagnosed with AVN of his right femoral head as seen on the MRI images. So the incidence rate of AVN of the femoral head is 10,000 to 20,000 patients in the United States every year. 3 to 20% of these patients often present with AVN after high-dose steroid treatments. 5 to 18% of all patients who have primary total hip arthroplasties end up having these procedures because of AVN. There is a strong male to female predominance of 3 to 1, and the average age of presentation is 35 to 50 years of age. There's often bilateral involvement in 80% of patients. And 3% of patients who have AVN often have multifocal involvement, which means that 3 or more joints are affected. The most common risk factors are those listed on this slide. Over 90% of AVNs are caused by corticosteroids and alcohol abuse. Hip trauma is also a significant risk factor, and this includes femoral neck fractures and hip dislocations. Smoking and prior hip surgeries are also among the more common risk factors. This slide lists some of the other risk factors, but they're not as common. There's SCFE in the pediatric population, sickle cell anemia, coagulopathy in hypercoagulable states, chemotherapy and radiation therapy as well. So the pathophysiology of AVN of the femoral head usually begins with decreased blood supply to the subchondral bone of the femoral head. This then causes osteocyte death and edema in that area. This then further increases the local osseous compartment pressure, which inhibits the blood supply going to the subchondral bone. This then upregulates the trap-positive osteoclasts, which then resorb the dead trabeculi, and the osteoblasts then lay down new bone. This new bone that is laid down is often weak, so it fails under weight-bearing activities, even walking. And so we have articular surface collapse, femoral head flattening, and disruption of the hip joint disarticulation. Ultimately, we end up having femoral and acetabular degenerative changes. So there's a difference between small and large lesions. In small lesions, the osteoblasts are able to successfully replace the necrotic bone with the new bone. However, in larger lesions, the new bone that forms often occurs at the periphery, which is the same site as the vascular ingrowth. The new bone that forms is often thicker and denser, so the vascular supply has a hard time penetrating through to the central portion, so it cannot repair the central portion of the lesion. As a result, we have weak acellular bone in the center, which is then at an increased risk of fracture, and then it can cause collapse of the femoral head. This is the major direct blood supply to the femoral head. As we can see, the most common is the medial and lateral femoral circumflex arteries, which often anastomose around the femoral neck and give off small retinacular arteries that then perfuse the femoral head even further. There's often variations in the MFCA origin. Most often they originate from the profunda femoral artery. However, there's a small amount that originate directly from the femoral artery. The foveal artery is running within the ligamentum teres, and this is a significant blood supply to the femoral head, especially in the pediatric population. There are 2 major anastomoses that provide the collateral blood supply to the femoral head. We have the cruciate anastomosis, which is between the inferior gluteal artery and the MCFA, and the trochanteric anastomosis between the superior gluteal artery and the MCFA-LCFA. On clinical presentation, in the early stages, these patients are often asymptomatic. They can complain of an insidious onset of medial thigh or groin pain, which is worse with stairs, incline, or impact. In the advanced stages, these patients often have deep and throbbing hip and groin pain. It can be unilateral or bilateral. It is worse with weight-bearing activities, and it can be alleviated with rest. In the early stages, the physical exam is mostly normal. However, in the advanced stages, these patients often have pain and limited active and passive hip range of motion. Passive internal rotation is often the most painful and limiting. And if it is severely restricted, it is often a sign of collapse of the femoral head. Of note, if patients who are younger than the age of 50 come into clinic or come into the emergency room with medial thigh or groin pain, and especially with decreased hip range of motion and limited internal rotation, it should increase your suspicion for AVN of the femoral head. So x-rays are often the first diagnostic imaging that is ordered for these patients. It's recommended to get AP and frog leg laterals, x-rays of the affected hip, as well as of the contralateral hip, since AVN can be bilateral in 80% of patients. So as we can see here in the example, there's something called the crescent sign, which is often indicating an impending structural collapse. And we can see that also a little bit in the patient's x-rays as well. Often in the early stages, x-rays are often negative and appear to be normal. As a result, MRIs are considered to be the gold standard. They are often highly sensitive and specific, especially in patients whose x-rays are normal. MRIs should also be ordered for patients who are minimally symptomatic. On T1 images, you can see a low intensity lesion in the anterior superior aspect of the femoral head. And the T2 images often show a high intensity lesion that is present, appearing like a double line sign. These are some other studies that can be ordered for these patients. CT scans are often reserved for more advanced stages of AVN, and they're reserved for trying to see if there's a subchondral fracture that is often not seen on the MRIs. Bone scans and PET scans can also be ordered, however, they're not as sensitive as MRIs. Angiography and biopsy can confirm the diagnosis, however, they're often invasive, so they're limited mostly for research purposes. This is a nice flow sheet in order to look at which test to order for your patients with AVN. If you have a high suspicion, the first one you want to get, as we talked, is the x-rays, AP, and lateral. And then depending on if they're negative or positive, you can follow the flow sheet to see if there's MRIs that should be ordered, CT scans, or if no further imaging is required. These are the two major classification systems for AVN of the femoral head. We have the Picot Arlett classification and the Steinberg-Upen classification systems. So the first classification system, it really looks at clinical symptoms, x-ray findings, and MRI findings. It does not account for the size or the location of the lesion, which are now considered to be two important factors for predicting treatment outcomes. However, this classification system remains to be the most cited classification for AVN of the femoral head. This slide goes over the 4 different stages. So stage 0 is where you have no symptoms, you have a normal x-ray, you have a non-diagnostic MRI. So it's really the preclinical stage. Stage 1 is where we have mild symptoms that are present, a normal x-ray, and now, however, we have an abnormal MRI. Stage 2 is where the symptoms persist or worsen. You have femoral head changes that are present, but there is no femoral head flattening or crescent sign present on the x-rays. Stage 3 is where the symptoms progress even further, and you now have a crescent sign that is present, but there is normal joint space. In stage 4, the symptoms progress even further, and the patients are in severe pain. And now we can see femoral head flattening with the loss of the joint space and acetabular and degenerative changes on the x-ray. The Steinberg classification system really looks at the MRI findings, the size of the lesion, and articular involvement of the lesion. The last 2 factors are factors that were not considered in the previous classification system. The Steinberg classification also differentiates between subchondral collapse from the femoral head articular cartilage collapse. Stages 1 through 4 are then further subcategorized by the percentage of femoral head involvement, and these are often key predictors for femoral head collapse. There are 6 stages in this classification system. Stage 0 is again where we have normal x-rays and non-diagnostic MRIs. Stage 1 is where we have a normal x-ray, but now we have an abnormal MRI. Stage 2 is where we have femoral head changes. Stage 3 is where there's a crescent sign that is present, but there is no flattening of the femoral head. Stage 4 is where we have a flattening of the femoral head. Stage 5 is where there's joint space narrowing or acetabular changes. And stage 6 is where you have advanced degenerative radiographic changes that are now present. So this is Kerbal's angle. So Kerbal's angle really measures the degree of femoral head necrosis from the center of the femoral head, and it measures the arc that is present. So we can calculate it based on the AP and the lateral, and the sum of that is the Kerbal angle. So this helps to determine the size of the necrotic region. So it can be small, medium, or large. If the sum of the arcs is less than 180 degrees, these patients end up having better outcomes than patients whose sum of arcs are greater than 240 degrees. Because MRIs are considered to be the gold standard and are able to evaluate AVN, especially in the early stages, the Kerbal angle was modified in order to allow us to calculate this arc of necrosis in the mid-coronal and added to the mid-sagittal to get the modified Kerbal method. So there are 4 different grades that are present depending on the size of the arc. And this study really looked to see if you could predict collapse of the femoral head based off of the sum of the arc. So if the sum of the arc was less than 190 degrees, 0% of the femoral heads had collapsed. And if the sum of the arc was greater than 240 degrees, 100% had collapsed. These are some of the non-operative treatment options available for these patients. There's limited weight bearing with a cane or a walker, activity modification, or physical therapy. However, these 3 options are not effective in late-stage osteonecrosis or preventing disease progression even in the early stages. Abstaining or decreasing alcohol or tobacco use, bisphosphonates, hyperbaric oxygen, and lipid-reducing agents are also options. However, they're not effective if there's subchondral collapse of the femoral head that has already occurred. These are some of the operative treatment options available for these patients. There's core decompression, osteotomies, vascularized fibular bone graft, femoral head resurfacing, hemiarthroplasties, and THAs. So this study really evaluated the trends of joint preserving and non-joint preserving treatment options for patients with AVN in patients who were both below the age of 50 as well as above the age of 50 between 2009 and 2015. What they ended up finding is that most often than not, around 97% of the time, most of the patients received non-joint preserving procedures. In patients who were less than the age of 50, only 5% had joint preserving procedures. And if they were greater than 50 years of age, only 2% had joint preserving procedures. As we can see on the figures on the right, despite the age, the most common procedure that is performed is THAs. The study looked at the efficacy and safety of core decompressions as a treatment option. Core decompressions are where the necrotic bone is removed pre-collapse and then it's supplemented with bone either allograft or autograft from either the greater trochanter or other regions of the proximal femur. What this study found is that there was a statistically higher success rate in patients who were in the earlier stages of AVN. It also found that composite bone marrow and autologous bone helped to improve the success rate and decrease the conversion rate to THAs. This study looked at pre-vascularized fibular grafting as a treatment option. So this procedure involves removing the necrotic subchondral bone, often in other procedures such as core decompression, and then we end up filling it with an autologous or allograft bone that is present, and then we transplant the vascularized fibular graft on top of it. So this then will revascularize the new subchondral bone and provide support to the femoral head. So what this study found is that all hips showed a decrease in the pain intensity, and there was an increase in the femoral head uptake of the radiotracer on the CT SPECT scans that were present at the 6-month follow-up. So this shows that the grafts were even viable at the 6-month mark. Osteotomies were also considered to be a treatment option for these patients, and this involves transferring the weight-bearing forces to other areas of the articular surface. Many different types of osteotomies can be performed, but the 2 most common are the TCBO and the TRO. The TCBO ends up doing better than the TRO, especially in terms of operative time, blood loss, post-op collapse, and post-op survival. The TCBOs also had a decreased conversion rate to THAs. The study also tried to see which patients would be ideal candidates for the TCBO. They found that patients who had hip pain, who were less than the age of 40, BMIs less than 24, who had a AVN classification score of 2 or 3, had medium-sized lesions, and had viable bone were considered to be the ideal candidates. This study looked at femoral head resurfacing and found it to be a treatment option, especially in younger patients with a higher activity level. There was a 94% survivorship at the 1-year mark. However, it decreases to 76% at the 3-year mark. 62% of patients had improvement in their pain symptoms. However, it was often variable from patient to patient. And 28% ended up having to be converted to a THA at an average time of 18 months. This was often due to femoral neck fractures, a high failure rate, loosening of the components, as well as inadequate pain relief by the patients. This study looked at comparing hemiarthroplasties and THA, especially in patients who had the classification of stage 3 ABN of the femoral head. And what they found was that there was a significantly increased amount of gluteal and groin pain in patients with the hemiarthroplasty group compared to the THA group. There was no significant difference between the mobility and the walking score abilities that were present. What the study found was that the THA group ended up doing better than the hemiarthroplasty group, especially in the stage 3 of the ABN of the femoral head. This slide has a nice flow sheet that we can use in order to see which treatment options would be ideal for our patients with ABN, and it categorizes them based off of pre-collapse and post-collapse. As we can see, most of the patients with post-collapse end up needing to have a total hip arthroplasty as a treatment option. So going back to our case with a 50-year-old gentleman who had limited internal rotation, hip pain in his right hip for the past year. His most common etiology for ABN was alcohol. He had no corticosteroid use, no smoking, no hip fractures, and no prior hip surgeries. He was a stage 4 on the classification system since he had the crescent sign that was present. He had a mild narrowing of the joint space, and he had some acetabular changes that were also present. So ultimately, this patient ended up getting a right total hip arthroplasty, and these are his post-op images seen on the right. So in summary, ABN is caused due to a vascular disruption to the femoral head. The most common etiologies are corticosteroid use, alcohol use, and femoral neck fractures. MRI is highly sensitive and specific for diagnosing ABN, especially if you have normal X-rays. Non-joint preserving and joint preserving surgical treatment options are available, and the most common treatment still remains to be total hip arthroplasties. These are my references. Thank you.
Yesha, I thought that was a great review of a very challenging topic. And obviously, I deal with a younger population. A lot of the kids that I see with ABN are kids with sickle cell disease or have undergone chemotherapy and have had high corticosteroid use. But we're obviously trying to preserve these joints, but some of them can't be preserved. I had a comment just for clarification. You made a reference earlier about the foveal artery from the obturator contribution, and that's really only relevant in the youngest of patients, and that circulation probably becomes irrelevant around the age of 4 or 5. So that's important to note. But from what you read, at your age, at 30, well, you're probably in your 20s, Yesha. If you had avascular necrosis of your hip and you had a significant Kerbal angle, what would your preference be? And I'll put it to the residents and the faculty. What would your preference be on how to pursue correcting your hip?
Personally, I think I would try the non-op treatment options first, and then if I was having significant pain and no improvement, I would probably try more of the joint preserving therapies, because ultimately, I think later down the line, as I approach the older age, I would definitely need a total hip arthroplasty, trying the other options first.
Yeah, and I think that I would agree. Anybody else?
I thought, so I was gonna, preface that to kind of, ask whether she had sickle cell or something else going on, and that might kind of, alter your. The other thing is, if you treat it conservatively and it gets worse, and it goes from a thick hot 2 to a 4, have you burned some bridges? Yes. So, devil's advocate.
Yes, for sure. And so, Yesha, I guess one other thing that we didn't totally cover is if you have non-operative treatment, how long does it typically take for that area to revascularize?
I'm sorry, could you repeat the last part?
Sure. How long does it take to revascularize?
If I looked at the literature for the fibular graft revascularization, that usually takes anywhere from 2 to 3 months, but it could also be present at 6 months. I would have to review for the non-op treatment options.
And I think that depends heavily on the size of the lesion too, and how much of a core decompression you can perform. But if you use Perthes disease as a model, for revascularization, the studies show us if you do perfusion MRIs where you give contrast and then take a time of flight acquisition of imaging and look at the actual flow in the small vessel system in the femoral head, you can get a good map of where your defects are. And if you have a lesion that's revascularizing on its own, it could take a couple of years. And so you're talking about, are you being non-weight bearing that whole time? At what point do you say this joint is no good? At how much time can you tolerate it? And these are hard questions to answer. I don't have the answers to these. But the fact is that non-operative treatment, can work. You can revascularize, but that doesn't wind up working out well for everybody. If you have an incongruent joint, as Dr. Bo said, you may lose some of your options if you start to get some degeneration because these joints can go south fairly quickly. And, even in a young person, I'm really grateful to have Dr. Harwood and Dr. Kairos in our community because some of these kids really do need total hips, even in their teens. And you can do that and you can help them. But I think the fact is that revascularization happens very slowly. So non-operative treatment, you have to be patient. Now, there are studies in Perthes disease where people are trying to actually stimulate more rapid healing by injecting BMP directly into the femoral head. Harry Kim's done a lot of work at Scottish Rite. And they've had some success, more success in animal models than in human models. But this is something that is still considered experimental. And they're working on some proprietary stuff to help augment the bone more quickly and try to get it to heal faster and speed up that timeline to avoid more collapse. And I think that the biologic treatment may be something that helps us in the future, but I think this remains a challenging problem for all of us. I thought you did a great job.
Thing I'll say is this is a disease that you really have to listen to your history because many times people don't come in and say, oh, hey, this is why I have ADN. There's a couple of people I picked up that had COVID and had steroids in their late 30s and they had this, even though x-rays were negative. So it's one of those things that listening to that, trying to figure out the why part of ADN is important. If you don't correct that, everything else we're talking about is so especially, kind of the default for this is going to be a hip replacement. And for me, according to the question, I have to figure out why that's hip replacement's not the right move. And if you're young and you're willing to go through, is admittedly a much longer rehab, and you can correct the underlying reason, joint preservation makes sense. If the answer to those are no, then we're going to have a much more predictable and frankly much quicker, easier recovery.
I'm not sure. So, admin, like Tom said, that can take a couple of years. So, extrapolate that to 2050. Independence.
Because you see so many of those cases with just like burned out AVN, all sclerotic in the head. And some of them go on to some collapse, and some of them go on to no collapse. But they have big, sclerotic scars in the femoral head.
So,
What I've read is that each etiology of AVN has its own kind of timeline.
And especially with the sickle cell population, you can get, it's not just one insult that you could get for AVN, you could get multiple insults in multiple joints. So you end up in multifocal categories. So I think it would be different than if you had an adult who did not have sickle cell. Thank you.
Oh, I go down. Please just get downloaded so that I run out of space.
So presentation.
Oh, I know, yeah.
All right, my name is Frank Search. I am a fourth-year medical student at Wood. I'll be presenting on pediatric both bone and forearm fractures, their surgical indications and medical management. My objectives is to review a clinical presentation to a case, go over diagnostic criteria, review the appropriate management for both forearm fractures. Then I'm going to explore the indications for operative versus non-operative management and do a literature review looking at some controversial topics. So we'll start with our case. We have a 15-year-old male who was riding his Healy shoes earlier today. Sharp turn, swung into a wall, so he stretched out his right arm to catch himself. He immediately had pain and noticed deformity. Never noticed tingling or head trauma or loss of consciousness. His past medical history is severe anxiety, and he takes sertraline 25 milligrams daily. On physical exam, he was alert and moderate distress. He was tender palpation in the forearm, non-tender on the wrist and elbow. His right upper extremity, he had a 3 millimeter poke hole on the lower aspect of the forearm, and there was obvious deformity. His sensation and motor function was intact, and his pulses were intact bilaterally. So we did initial imaging. We have an APN lateral here. We have a skeleton, the immature forearm here with a radial and ulnar diaphyseal fracture. It's moderately displaced, and we see minimal convolution. We also have orthogonal X-rays of the elbow and wrist, evaluating for ipsilateral injury. If you wanted to look at rotational malalignment, it's kind of difficult to look through radiographs, but you could look at like the bicipital tuberosity of the radial styloid. They should be 180 degrees apart on the AP view. On a lateral view, you would want to look at the ulnar styloid, which would be posterior, and the choroid, which would be anterior, and also 180 degrees apart in that lateral view, and you can kind of assess for any kind of rotational malalignment there. So this patient was put in a temporary sugar splint for future definitive management. The wound in the ED was irrigated with 1 liter of betadine. Antip was given, antibiotics were set for every 8 hours, and the patient was given Toradol and acetaminophen for pain control. Before we get into surgical and definitive management, I wanted to take a step back and go over more of the general facts about pediatric forearm fractures, diagnostic criteria, and classification systems. The literature is variable here, but forearm fractures account for up to 18% of all pediatric fractures. The mechanisms are most commonly indirect trauma as opposed to direct trauma, and they have often rotational components to them. Like this case, fall on actress arm are very, very common. You'd want to look into classification systems through kind of a systematic approach. The anatomic location, most common for pediatric forearm fractures is distal metastasis. Distal forearm fractures account for 75% for location. Others, you have 20% of the time it's a mid-shaft fracture, another 4% of the time it's proximal segments. You want to look at the pattern, which is very similar to other fracture patterns. Comminuted, transverse, oblique, spiral, again, rotation can affect the fracture pattern. You want to look at the displacement, if it's displaced, as well as the angulation, whether it's slow or over. You also want to assess soft tissue, is it closed or open, that'll affect your management strategy. You also would want to look at bony features. Now in pediatrics, it's unique because their tissue or their bone is softer, so you can get buckle fractures, coarse fractures with compression and no cortical dispersion. You can have green stick fracture, with intact cortical bone. Cortex is disrupted on the tension side. You can have just a complete fracture or just plastic deformity. So again, you want to take all these considerations into how you're going to be having health management. Let's go back real quick. Another really important thing is, to consider the associated injuries here. 15% of the time you'll have an ipsilateral supracondylar fracture. Floating elbow, I think they call it. You can also have a neurological injury associated with that, with the median nerve. Other really important associated conditions is the Galeazzi fractures, Montesia fractures, you can have the Essex depressy as well. So any kind of ligamentous injury or instability that can be resulting from these falls, you need to assess for. If you notice on the APA or lateral that there was a single bone injury, you need to be more careful. So I also want to do a little very quick anatomic worldview and some of the forces that are occurring here. The ulna is straight, static, and maintains the form and stability with torsion stress. The radius and ulna together, they're attached at the proximal portion by the annular ligament. More distally, moving along the diaphysis, the interosseous membrane, distally, the RJ and TSCC complexes. It's important here to consider, the radial bow. You have the lateral bowing of the radius, and later on we'll talk about why that's important to maintain your range of motion. Talking about range of motion, your physiological range of motion for supination should be between 80 and 120 degrees. Pronation should be 50 and 80 degrees. For deforming muscle forces, when we talk about proximal third fractures, the biceps and supinator flex and supinate, and the pregnant areas and quadratus pronate the distal portion of those. The brachioradialis can dorsiflect and radial deviate distal fragments, and your wrist flexors and extensors and thumb abductors can also call fracture deformity. So you want to consider all these deforming forces on how you're going to reduce either non-operatively or operatively when assessing your management strategy. So treatment goals, very generally, you want to restore length, alignment, rotation, restore normal function, the normal range of motion. Younger patients, as we're all probably well aware, have very strong remodeling potential. As you kind of get older, that remodeling potential decreases, and as you become skeletally mature, you need more anatomic reduction. And all coming into your management strategy. So we're going to start with non-operative management. Normal function is often achieved with non-operative management alone. That includes a closed reduction and immobilization of the both form fracture. That entails, reduction with a combination of traction and manipulation with 90 degrees of flexion. Once you have acceptable alignment, the cast is applied while the arm is still in tension. You want to keep the arm neutral or supine arm positioning. You want to include that anterior and posterior compression over the interosseous membrane. That can help with the radial bowing and help later on down the line have a more anatomical alignment to maintain that range of motion, as well as a 3-point mold, because you want to limit any kind of failure of reduction. Another important point here is comparing how you want to create your immobilization. There's been quite a bit of literature that's comparing long arm casting and short arm casting. The long arm cast is thought, it does prevent flexion extension and rotation, which can limit the angulation and displacement risk that you see. But there is strong evidence that shows that well molded short arm casts can control supination and pronation appropriately. There was a 2006 study that showed no differences in displacement between the two groups, and potential benefits to including patient in a short cast with better range of motion early on. The Kerbal et al. Identified the CAS index as being less than 0.8 as an ideal number. Basically, anything above this is associated with increased risk of loss of reduction, which means increase in 10 degrees of angulation or greater than 20 degrees of displacement compared to your post-reduction films. Some debate, as I mentioned before, is between the short and long casts. When you're assessing this, and if you did put someone in short cast and you're worried about loss of reduction, most of the time this is occurring within 3 weeks. So if you keep a close eye on your patients in the first week and the next following 2 weeks, you can capture this loss reduction and do a re-reduction if you need. So if we're doing non-operative management or operative management, we have an acceptable reduction guidelines. These guidelines are commonly established by Noonan and Price. It's commonly well accepted across pediatric orthopedic surgeons. For 0 to 10 years, you have a lot of remodeling potential, so you can accept greater degrees of angulation, rotation, and bayonet apposition. So for angulation, we accept less than 15 degrees, rotation less than 45 degrees, and bayonet apposition less than 1 centimeter short. As you age, again, that remodeling potential diminishes. For the proximal and mid shaft, we accept less than 10 degrees of angulation, and distal is less than 15 degrees distally. That's mostly because your distal radial and ulnar growth plates are responsible for 75 to 80% of the longitudinal growth each year for each part of the bone, which is why distal fractures have high remodeling potential. Fractures closer to the elbow. Rotation, we accept less than 30 degrees, and we don't really accept bayonet apposition after 10 years. Again, some of these are flexible and controversial, and people do accept more or less depending on your preferences and your experiences. But these are the general guidelines. As you approach skeletal maturity, you need a perfect anatomical reduction to ensure adequate range of motion. So if your non-operative management failed, or there was absolute indications for operative management, those would include unstable or irreducible fractures, an inadequate reduction or failure of reduction, or a reduction that later presented with greater than 10 degrees proximal or mid shaft or 15 in the distal shaft. Other, more rare causes of operative indications would be neurovascular compromise, open fractures, or pathological fractures. Again, it's well established in younger children, but as you age in older children, there's more disagreement in terms of acceptable reduction levels. Operative techniques include the IML and open reduction and fixation. You can do that percutaneously, or you can do it open. The IML, their elastic definitive nails are standard choices due to elasticity, osseous integration, and their biocompatibility. Usually you would do the ulnar nail first and then integrate the radial nail. Integrate the radial nail. The advantages to a IM nail: they're smaller incisions, you have little periosteal stripping, less soft tissue injury. Some studies suggest less bone loss and less operative time. Disadvantages: you need a second procedure to remove the nails. Immobilization after insertion can be longer as compared to an open reduction fixation. Complication rates range from 17 to 42%. You have very similar complications with both treatments, infections, skin irritation, tendon injury, non-union refracture, or even compartment syndrome. There's other controversies throughout the treatment, single nail or stellar nail, etc. So nails are routinely moved at 6 months and up to 9 months, but if you move it earlier than 6 months, they're associated with higher fracture rates. So something you want to look at, especially in adolescents, children that you might consider an nail for. Plating can result in more complete anatomical correction of malrotation and restoration of that radial flow we were talking about. But again, it's increased soft tissue dissection and increased exposure. Oftentimes they're used with comminuted fractures or fractures that are located at the apex of the radial bow or along the metaphysis or the articular surface. Again, in adolescents or older teens, they may have no remodeling potential. You would include those as well. There's also hybrid fixation. where you're kind of combining these two techniques. You can do conventional plating for the ulna, which can preserve that radial bow and reduce non-union and via form rotation. And then you can do the IM nail through the radius. Similar complication profiles in all three of these techniques, literature ranging between like 15 and 40% for each of them. It's very important that we include a classification, not just for the both bone-formed fractures, but for open fractures as well. The Vascularized classification is a commonly known classification scale for fractures. 2 to 9% of fractures in children that present to the hospital or tertiary centers are open, and they're considered surgical emergencies due to the risk of infection. They have significant side complications that are associated with them. You can have 11% risk of Cartman syndrome, 11% risk of nerve injury, and 2% risk of vascular injury associated with these injuries. In pediatrics, you're mostly going to see 1 to 3 in the Systole classification scale. Usually, you're not going to have smaller wound size, less soft tissue damage. These, the bone injuries are due not necessarily due to direct trauma, so they're going to be less severely with open wounds. In this case, our case was a class 1 Systole Landmarks classification. If we were to do an open approach, we use the anterior approach, which is a Henry approach. Landmarks for the incision through the biceps tendon and muscle. The Systole landmarks will be the radiociliary process. In your superficial dissection, you are developing an interval between the brachioradialis and the flexor carpi radialis muscles. The radial artery lies deep to there, so you need to be careful of that when you're doing that section. Another, potential pitfall here is, the superficial radial artery is very close there underneath the radial and the lateral aspect of the brachioradialis, inferior lateral aspect of the brachioradialis. And if you were to injure that, potentially you can cause a painful neural, as well as injury to the posterior interosseous nerve, which can cause a neuropraxia that can last up to 6 to 9 months. So here we have, we moved forward for this patient with IM flexing nails. We did it percutaneously. So the nail was initially, again, we started with the ulnar nail. The ulnar IM nail was introduced in the anterior fashion to a longitudinal incision, just 1 centimeter distal to the operculum hypophysis on the lateral side. After it was inserted, you kind of look at the longitudinal form of clinician, and go to radial IM flexing nail as well, and then you assess the stability, the range of motion of the arm to see, and then you do the intraoperative images to see how your reduction is. Post-operative imaging, after we put the patient into a splint, you can see good anatomical alignment here, with, no really displacement, good CAS index as well. A 2019 study demonstrated that adolescents utilize more elbow flexion and impingement, less supination in children. So when you're considering your operative management mechanism, you would want to take this into consideration because they might need greater range of motion and they have less remodeling capability. So whether you're doing IM nails, you have to make sure you're identifying the type of fracture, whether it's common or not, whether the cortices can line up and key in appropriately. And we can discuss why we chose what we chose here later on. So for a literature review, we wanted to ask a few different questions. There's a lot of potential topics here. We chose, can open forearm fractures be managed in the emergency room rather than brought to the OR? And when I'm talking about open forearm fractures, I'm mainly talking about here. So there was a 2017 multi-center retrospective study that looked at 219 patients between 2 and 18 years of age, all with type 1 open fractures. They compared non-operative incision drainage in the emergency room compared to operative incision drainage. The outcomes were infections, duration of hospital stay, and general complications. So here we see Overall, there was a similar infection risk, approximately 2% in the literature, which was also found here. The patient's non-op had shorter length of stay, 16 hours compared to operative 9 hours. Generally, complications were increased in operative patients with 3 surgical emergencies, compartment syndrome, and acute carpal tunnel. It wasn't statistically significant, and that could have been related to that. With non-operative treatment, you avoiding risk of anesthesia, you have generalized reduced costs, increased length of stay, less operative trauma. It's possible that the surgical IND could be worsening soft tissue injury, so you could be devascularizing some of the bone and stripping some of the periosteum that can help. And again, this study showed all type 1 fractures, but I highlighted here on the left the fracture type of the wrist and forearm, just to illustrate that the majority here were actually forearm wrist fractures. So I think it's very helpful. Here is a current concepts kind of review of the question, can open forearm fractures be managed in the emergency room? So there was, at the bottom of this table here, this is the study I just talked about here, but there was other relevant ones that I thought would be important to kind of reinforce the point. The Skaggs et al. Was a multi-center retrospective looking at the forearm tibia. Again, most of those were forearm. It showed no significant differences in the rate of infection and treated. The fracture was treated between 6 and 24 hours with a 2% infection risk. Loft et al. Was a prospective non-surgical management of IMD with closed reduction in ER. They gave 3 doses of IV antibiotics over 24 hours and no follow-up oral antibiotics. And they had 0 infection, which I thought was insane. The other studies here are also strong representatives of what I'm basically getting at, is that, a type 1 open pediatric forearm fracture can successfully be managed without a formal operative IND. Type 2 and 3 open pediatric forearm fractures, they should be managed with operative reanimation agreement and fracture stabilization. But I think it should, we should question whether you could manage type 1s non-operatively and newly put in place to see how that might work for your own institution. Over here, I have a nice little schema, kind of going over the literature and kind of determining optimal management depending on the specific criteria, what kind of fracture it is, how much growth they have remaining, and what the condition is. So, in our case, we had a 15-year-old male, type 1 open fracture. It's greater than 10 years of age. It's a complete fracture. We go over here at the far right. Here it says surgical treatment here. Come down. Age greater than 10. IM nails, double plate, hybrid fixation. With our 15-year-old, he was clinically immature. Like he looked like he still had a lot of skeletal growth left. So to say he had 1 or 2 years left, it might be true. But his cortices were well approximated. It was non-comminuted. We thought we could get a good anatomical reduction with the flexing nails associated with the literature showing similar outcomes between plating. We chose to move forward with nails. And that's all I have. So thank you very much. Please feel free to ask any questions.
How long will those nails stay in the forearm?
Well, you want them there for at least 6 months. Take them out then. But again, I mentioned earlier that if you take them out earlier, there can be a higher risk of refracture or displacement or loss reduction. So,
Can he play contact sports after it heals with the nails in? Considering the fact that football season starts in a couple of weeks, what if he was a 15-year-old football player?
I don't think I'd want that. Yeah.
I have an opinion about that.
Really?
I would say no. But yeah, I would love to hear your opinions.
Go ahead, Tim. Let's hear it.
Well, for the 15-year-old that's actually looks more mature and his growth plates are more closed, you're going to treat him like an adult. He's going to get plates. And if he's got plates and he's got enough time for healing, I'm going to let him play with plates in. with flexible nails, he's not playing until honestly after the nails come out and after there's like full maturation, consolidation of the fractures, because they're just so easy to re-break. I mean, that's the sort of the fatal flaw. And the ball player that has plates in, I'm not taking those plates out until he's done playing ball.
Biggest thing there is you had great reduction. Right? So
Yeah,
that's probably the most predictive thing of stability, plus also the healing. So, and it's interesting. I mean, I'm not that much or farther along than many of you. And when I was a resident, we were taking these, somewhat emergently down the river. Right? So it's kind of interesting to see how much has changed. I think this now a grade 1 open fracture. It's routine not to take that right away and wait till the morning and do that, but and that was different. So who knows what that's going to be like in 10 years, but it's important to kind of, I think this is a really good example of the literature, knowing what all that says. This doesn't need to go to the OR.
I do think we need a better way to, I like flexible nails for the right patient. I don't want to make like I'm knocking that, but it's hard to keep those in for as long as we want to, because they do irritate the skin. We need a better way of like putting those in and cutting them off without having them so difficult to remove if you cut them too short, and so prominent if you cut them too long. I think it's a great modality for fixation. It's just not a perfect technique.
Just as you see that we did a nice literature review on the non-managing type 1 injuries in the emergency room. Just to throw darn at that one, when I was a resident, we had a pediatric patient transferred to Robert Wood with acute botulism toxis, and the patient had been managed at an outside hospital. So this is a long time ago. I was a resident a long time ago. There was a little pinhole wound that they just kind of said they washed out and cast at the kid. And, in a few days, the kid developed acute botulism. And we took the patient to the OR and opened the incisions, and there was grass on the end of the bones. So even though you see these tiny little wounds, the bones, you don't really know what happens out in the world. The bone can go out, suck in dirt, and go back in and look like you have a little puncture. Obviously, something came out enough to drag dirt and grass and cause this one patient, botulism. But so that's my experience in life. So if I was my choice whether to treat it in the ER or OR, because of my bad experience, I'd probably say, take the patient to the OR. But like Dr. Buckley said, you have to stay up with the literature, and things are changing. And these cases are being managed in the ER, appropriate.
But if they're trying to, we send people home with antibiotics, we are not. We just give them just one dose, not a full 24 hours.
So it totally depends, I think, on the attending, and usually it's only for like true one football. Not like less than 10 years, it's like one little.
And some people are, it's like 50-50. That's it. Definitely not.
So there was no difference within 24 hours. Any other questions?
Only Charlie Gatt could get a patient with botulism.
And I was not a black cloud when I was a resident. So.
Thank you very much.
Yeah, that's cool. Now we're gonna go hustle over there.